think 1987 or 88, so going on 30 years since we first met. And he was the non-vascular IR fellow, and I was the angio fellow at a time and a place where those services didn't even really talk to each other. And we thought that was crazy, but our bosses didn't like each other at all. And so there was no chance that we were going to ever work together until those two guys left. And we combined the services, and Horacio and I pretty much blended vascular and non-vascular into one group, like everywhere else in the world. And he taught me how to do a nephrostomy, and I taught him how to do a TIPS. And we've stayed close professional and personal friends since that time. And it's like, it's part of spring. You know, the weather turns good, and I come down to Shreveport. And it feels good to be here. So I almost know my way around this area of the hospital as well as my own. So anyway, we're going to spend about an hour or 50 minutes talking about GI bleeding and IR and radiology and what role we can play in that clinical problem. It's not a very common problem that we see very often. Most people that have GI bleeding can be treated conservatively and they get better on their own, but a small percentage don't, and they can get very ill and often need our help. And the story of management of GI bleeding and IR really goes back all the way to the beginning, even before there was the term interventional radiology. I don't know if any of you know where that term comes from. Anybody know? It was coined by a guy named Alex Margulis. He was the head of, he was the chief of radiology at UCSF. And in about 1967, he wrote an article in AJR where he coined that term, because no one had a name for what it was if a radiologist fixed something. And he called it interventional radiology. And our field really starts off with GI bleeding, all the way back to 1963, when Stan Baum at Mass General first reported doing an angiogram and showing bleeding on an angiogram, so demonstrating a site of bleeding. About 6 years later, he was the first person to describe using vasopressin, which we'll talk about briefly, as a drug to stop the bleeding. So it was that light bulb concept. You're an angiographer and you're doing a diagnostic study and you think, wait a minute, I've got this catheter right where I saw this problem. Maybe I can fix it with the catheter. And that's how IR started. And then back in 1972, Roche and Dotter, I hope you've all heard of Charles Dotter, the man who's considered the father of IR, first described using autologous clot to stop gastric bleeding. So well before angioplasty was ever an idea, we were treating GI hemorrhage as interventional radiologists. So to start as kind of a broad overview of this field, you know that we categorize GI bleeding by its location and its source, and we try to divide the bleeding into an upper source, meaning proximal to ligament of Treitz, or a distal source, because the diseases that causes bleeding in those two places are different. The way they present is different, and the way we manage them is different. Remembering that sometimes we can't tell which is which, and that upper GI bleeding also includes any bleeding from the biliary system or the pancreas in through the ducts into the GI tract. So you can have bleeding from the liver that presents as GI bleeding. Also important to remember that bleeding can be from arteries or veins. In IR, we're very good at identifying arterial bleeding and treating it. We don't do it, we don't see it and treat it in the same way. So it's important to think when you're a patient you think has arterial bleeding, maybe it's not arterial, maybe it's venous, and maybe what I'm doing is not going to identify that bleeding source. Again, there are myriad causes of acute GI bleeding. It's important, certainly as a resident, to know the most common ones. In the upper tract, varices, portal gastropathy cause about at least a third of major bleeding. So this is something we won't see on an angiogram, seen better with endoscopy. The diseases we tend to handle on the arterial side are peptic ulcer disease, inflammation of the stomach or the esophagus, malleolized tear and tumor, And then there are a variety of odd zebras, weird birds that can also cause GI bleeding that you need to at least keep in the back of your head. For lower GI bleeding, majority of cases will either be diverticular disease or a vascular anomaly such as acquired Angiodysplasia or congenital AVM. Probably the third most common cause is iatrogenic. It's the endoscopist snipping off a little piece of tissue that looks abnormal during a routine colonoscopy and getting bleeding from that. And then again, a variety of other tumors, vascular anomalies, inflammatory diseases, inflammation, ischemic bowel, and so on can also cause GI bleeding. In general, we can't tell what the cause is. So we can find it and we can treat it, but we can't usually tell you what's actually doing it. A couple of important pitfalls in categorizing bleeding. Number one, apparent lower GI bleeding. So a patient has bright red blood per rectum. About 10 to 15% of the time, that's an upper tract source. So you will be confused. And if you don't think the celiac artery could be causing that what seems like lower GI bleeding, you will miss the diagnosis. Remember that an upper intestinal source can also include the pancreas or biliary duct. Third, very important, that venous bleeding can mimic arterial bleeding. So if you don't know whether or not that's the case, consider endoscopy, particularly in patients who have documented varices or liver disease and are predisposed to variceal bleeding. And finally, the converse is if you've got a patient who's got known cirrhosis, known variceal bleeding, a small percentage of them, but significant, are going to have, even though they have varices, are going to have an arterial source of bleeding. They have varices, but there's something else causing it. And you don't want to miss those people, so think both ways. Somebody could have variceal bleeding unbeknownst to you. Somebody with known varices could have arterial bleeding. So what are we going to do in the next 45 minutes or so? We're going to talk about how do you find the bleeding, how do you fix it, and then finally, what's an approach to dealing with each type of clinical scenario? And there are 3 or 4 ways these patients present. So how do we find it? Well, the first step is to either see it directly or see it with an imaging study. And obviously we know conventional endoscopy and colonoscopy are the mainstay of diagnosis. There are a number of advanced endoscopic techniques that allow us now to see the small bowel. We come into play when we consider imaging either through RBC scanning, CT angiography, enterography, or catheter angiography. So obviously the endoscope is the primary diagnostic and therapeutic tool for GI bleeding. It's changed the whole way that radiology and IR gets involved because the GI endoscopist can find the bleeding and treat it most of the time. So we get the more difficult, obscure cases, particularly in the lower tract. So it's the first line tool for acute upper GI bleeding, largely because it's very accurate, it's fairly safe, and it's widely available. We can determine the exact nature of the disease because we can see it, and we can take a piece of tissue. We can't do that with imaging. We can see venous bleeding you won't see on an angiogram. And it also allows direct therapy at the very same time. So we can use a sclerosant or thermal ablation or band of Varix and treat it. So you diagnose and treat at the same time. So endoscopy is mainstay. Certainly the upper GI tract, virtually everyone gets endoscopy. In lower GI bleeding, it's more controversial. Most, at least in our institution, our GI folks will say, we don't do it because all we just see is blood everywhere and we don't know what's bleeding. It's just, or the patient is not prepped and we see stool, it's not useful. When you actually look at it more rigorously at studies where they actually have tried to make a lower a colonoscopy or lower endoscopy applied for acute bleeding, they have better success. There is a significant likelihood that you can make a specific diagnosis and treat it if you actually are aggressive about doing endoscopy or colonoscopy. The cons are that you do need to do some kind of bowel prep for most of these people, and that can be difficult and time-consuming in an acute setting. And there are other studies, one of them is among those listed here, that show that doing delayed colonoscopy, that is waiting, doing the 12-hour prep, and then doing the colonoscopy later, is just as effective as doing it immediately. So it's going to be an institutional thing. If your GI people are willing to do a colonoscopy, great. If not, you're going to have to do some other kind of imaging. The small bowel used to be the blind spot. for GI. Basically from jejunum to the TI, that was an area they just could not see, and they relied on imaging to find problems. Not true anymore. Now there are a whole variety of techniques that allow endoscopists to see almost the entire small bowel well. So if these techniques are not being employed where you are, or here, it's something that should be, because you really don't need to use imaging to see the small bowel anymore. So what do we do? So a patient comes in, and let's say the patient has had endoscopy. If they find the disease and treat it, we never hear about it. But if they detect it, but it's not treatable, the recommendation is that we go right on to angiography and embolization. If it is either not detected or not done, then we got to choose what to do. Do we do a red cell scan? Do we do a CTA? Do we do enterography or angiography? And that's what I want to talk about briefly. Those 4 techniques. Red cell scanning, I think you're all familiar with. It's easy, it's quick, it's safe. It has one particular advantage in that it can detect slow and intermittent bleeding, because you're showing the bleeding that's happening over a period of 12 to 24 hours. So if you're bleeding intermittently, you may be able to detect it with this study and not with others. It's quite sensitive, it's moderately specific. In some cases it will localize bleeding, although we all know that can be, it can give us misinformation about the actual site. Another point that I would make is that the accuracy can be improved with SPECT CT imaging, and I'll show you a case a little later on where using that technique and asking the nukes guys, would you please do that, can be helpful. And this is the typical case where you see a little arrow sign, a little bleed right here up in the hepatic flexure, and then the contrast begins to pass more distally, and in fact, that correlated very nicely with this hepatic flexure bleed right there. CT angiography. Let me ask the group, do you use this routinely for GI bleeding? Yeah, there's kind of some are saying yes, some are saying what?
It kind of comes and goes.
It comes and goes. It comes and goes where we are, and I think that's a problem. It really shouldn't. I think it should be the first line study. Imaging study, but it's not yet where we are, and not in a lot of places. You make the diagnosis based on contrast appearing within the bowel lumen, not in the wall, on the arterial phase, and that will then usually progress into the venous phase of the study. If you only see the venous phase, that suggests venous bleeding. In addition to showing extrav, it will also show abnormal vascular structure. So it can, if you do it well, detect small vascular anomalies that aren't bleeding at that time. There's a very specific technique you need to use. So you don't just, it's not a triple phase study for looking for HCC. It's got to be done with a certain protocol looking for intestinal bleeding. And this is an example from UW. We don't have many because they don't do it very often. But this was a patient who had actually obscure bleeding. So it had endoscopy, red cell scans, angio. They couldn't find anything, and they finally did this study. And what it shows is this focal pool of contrast that was not seen on the non-contrast study, right here in this jejunal loop, and you can see it again here. And the benefit of that is it told us there's a bleed, there's an abnormality here. Do an angiogram and look for it, and we did that, and in fact we found it. Now, we probably would have found that, if it had been bleeding, we probably would have found that if we had just done the angiogram, but we might not. So the advantage of the CTA is that it told us there's a bleeding, there's a problem here. Yeah, go ahead.
So when the CT angiography is negative, then what's the protocol? Then you don't take the patients to catheter angiography, or you still? If it's
absolutely negative, we will not do catheter angiography. But we don't do enough studies that are negative for us to be at that point. What will usually happen then is if it's negative, the patient probably has stopped bleeding. If the patient starts to bleed again, we will probably recommend that we do provocative angiography. So again, if in a place where they do a lot of this, I think a negative angiogram is a useful screening tool. Where we are, it's going to be harder to convince our referring docs to not do it, but that's the way I think we should do it. But again, you have to have enough experience for the imagers to say, yeah, I really believe this is truly negative, and not just, I'm not sure. There are several things that can mimic bleeding on a CTA or cause you to miss it. Intermittent bleeding is the biggest problem. Hyperdense mucosa, there are artifacts you need to be careful about, particularly pills. And then subtle vascular lesions that are not bleeding. It takes a fair degree of experience and confidence to be able to call some very small vascular anomalies in the wall of the bowel an AVM that a surgeon should operate on. But the only way we're going to make this useful is if we start and get good at it is if we start using it routinely. And frankly, it's been a bit of a challenge in Seattle to get our CT imagers to do that. So how good is it if you work hard to do it? I think it's pretty good. This is a meta-analysis from a couple of years ago. It looked at 22 studies that included almost 700 patients, only with acute GI hemorrhage, not minor bleeding, not chronic bleeding, and they were only cases where there was a reference standard to prove the bleeding, either endoscopy, catheter angio, or surgery. And if we look at the sensitivity and specificity all over the map, but the mean numbers are pretty respectable. And this to me suggests that CT angiography has an important role to play in GI bleeding. We just need to do it more and we'll get better at it. CT enterography, are you using that here at all for GI bleeding? We do not use it in Seattle. Anybody? Somebody just. Okay, and we were just talking about CTA for detecting GI bleeding and the fact that in Seattle we're not doing as much as we should, and it sounds like that's maybe true here too. We should be using it more often than we do.
CTA?
Yes.
We always try, I always try to ask for a CTA before any kind of,
But it can be hard to get, and there are times when I don't think and we'll talk about this at the end of the talk, there are scenarios where I think getting a CTA is not the thing to do. You should go right to catheter angio. But particularly the patient with slow intermittent bleeding, I think a CTA is valuable. CT enterography is another technique. I have no personal experience with it, but I tell you about it because it is described. The rationale for the agent which is used, which is volumen, is that you can't use, the idea is we're going to try to basically look at the wall of the bowel. You can't use standard oral contrast because it's too dense and patchy, so you're going to miss what we're looking for. Water is useful, but it passes through too quickly. So volumen is a low density, so-called negative contrast agent. It will distend the small bowel and it will remain in place long enough to be able to see abnormalities by the time you do the imaging. And again, I'm not going to read it, but there is a specific technique that you use, a specific way to administer the agent and then do the scanning to be able to detect lesions like this. And this is from the literature. I have no fresh cases, but this is from a couple of years ago in radiology. And these are two apparently surgically or biopsy proven cases of GI bleeding here from a pancreatic ectopia. I'm astounded they picked that up, but supposedly they did. But you can see how beautiful the wall of the bowel can be seen with the right technique. And then here's another case of small bowel angioectasia. So this is where even catheter angiography is tough. So anything we can do to help us is going to be useful. And these actually were called as angioctasias, so it's sort of small vascular anomalies, and operated and removed and the bleeding stopped. So again, this is going to take meticulous technique to be able to see this, but you can do it. And again, what are the results? Again, much less experience than with CTA. This was in the meta-analysis of actually a fair number of patients, again, almost 700, comparing CT enterography with either capsule endoscopy, which is now kind of the gold standard for the small bowel, or with angio, and it was not as good as capsule endoscopy, so not as good as direct visualization, but it was comparable to angio. So I think, again, it's another complementary tool. These patients, the simple case of a diverticular bleed, you find it, you treat it, you're done. It's the cases where they bleed intermittently and you've got to try, and you're not detecting it, that you've got to consider these other more esoteric techniques to be able to find bleeding, because it can be very hard. So when do we use angiography? This is the summary of the indications as I look at them. If there's ongoing massive bleeding, whether you found the bleeding with endoscopy or colonoscopy or not. Obviously, if you find something on imaging, you do angiography largely to treat it, or maybe to prove to the surgeon it's there and you need to treat it. If you're unable to find a source of upper GI bleeding, or you can't treat it properly, or if you fail endoscopic treatment, if you treat with endoscopy and it recurs, angiography can be useful. And if surgery fails, you should also probably do catheter angiography. Protocol. If you think it's upper GI bleeding, obviously you start with the celiac artery. If you have evidence that it really is upper tract, I do celiac, and even if I see nothing, I do a left gastric and a gastroduodenal, because you may detect bleeding on a selective study that you don't see on the non-selective study. And then consider the right gastric artery. Maybe there's bleeding along the right portion of the lesser curve. There can be splenic artery branches that feed the stomach. And there can even be common hepatic artery branching. You may not see the right gastric, maybe it comes off the common hepatic, or maybe there's biliary bleeding, hepatic artery aneurysm, pseudoaneurysm causing hemobilia and GI bleeding. So consider those arteries occasionally, and then consider the superior mesenteric artery, whose first branch feeds the duodenum and may be the source. So that basically is celiac and then superior mesenteric if you see nothing there. For lower GI bleeding, some of my colleagues start with the IMA, and they do that so that the contrast in the bladder doesn't obscure the rectum. I have not seen that to be a problem, but one could argue do that. I start with the SMA because that's where most of the territory is in the lower tract. You want to make sure that you're complete. Don't miss even a little. Don't miss a square centimeter of that, and it may take a couple of runs to get that, because that may be where the bleed is. And if you have any guiding information about where in the bowel the bleed might be, use it. So if you've got, for example, a CTA that says, I think the bleed, or a nuke scan, I think the bleed is in the proximal jejunum, then I'll do the SMA, and if I see nothing, I'll start picking off individual jejunal or ileal branches with the microcatheter, and you'll often pick something up. So SMA, if that's negative, I go to the IMA. If that's negative, I'll almost always do celiac. Maybe you're wrong. Maybe it wasn't lower GI bleeding. Maybe it's brisk upper GI bleeding. And then rarely internal iliac angiography if you think the bleeding is particularly rectal, because it may be a rectal branch of an internal iliac vessel rather than a mesenteric artery. What are you looking for? Two things, bleeding or an anomaly. So this is the classic appearance of bleeding, and that's usually going to be fairly apparent. Sorry about that. You see extravasation. Now that can be easy, or it can be pretty hard to see, or difficult to distinguish from artifact, and it may take some time looking between subtracted and unsubtracted images, different projections, selected projections to prove it, but ultimately you should be able to detect if there actually is bleeding or not. So you look, and this you're going to see in the arterial phase. Then when I inspect the angiograms, I move to the capillary phase. And I look at the capillary phase, and I look at the arterial arcades, and I look for two things, an early draining vein or any tangle of vessels. And this is a good example of that. This is the sort of the capillary phase of selective SMA angiogram, where we see the arteries coming in, but we also see this little tangle here, but as you can be confused. You can make that up easily. What's more important to me is this tram track sign. So artery, small, coming in, vein, larger, less distinct, running back. The tram track. Flow in the artery, flow out through the vein. That's a vascular malformation. And you can follow it all the way there. And sometimes all you'll see is that tram track, what is it clearly a vein, and only then will you follow it back and see the abnormality. And this was a proven AVM. So you're looking for two things, a bleed or a non-bleeding vascular malformation. So how good are these techniques? The residents have seen these numbers, they're on the boards, they don't have much meaning. These are all based on animal studies and phantoms from a long time ago. So the actual numbers, I think, are meaningless. The relative sensitivity is important. So scintigraphy is about 10 times as sensitive as a catheter angiogram. CT angiography is more sensitive than a catheter angiogram, but perhaps less so than scintigraphy. So I think just knowing the relative ability of each technique to detect bleeding is important. The absolute numbers are not that important. How good is catheter angiography? Pretty good. Specificity, close to 100%. Sensitivity varies a lot, and that number has gone down with time because we're only getting the hard cases. In 1985, we got everything, and so we picked up all the duodenal bleeds. Now we get the hard ones, and I think our sensitivity has fallen. I would say in current practice, probably about half of the GI bleed studies, angios I do are positive, if that, which is a little disconcerting, but I think that's probably a pretty typical number. Rebleeding after a negative angiogram, so how many times did we either miss something or they had intermittent bleeding and they started bleeding again? About 1 in 3. So what are the outcomes? There are 3 things that can happen when you look at the angiogram. We'll talk about what you do. It's bleeding, either focally or there's diffuse hypervascularity. You find what you think is a vascular lesion or it's negative. So if it's bleeding, then we're going to treat it almost always. And our choices are operation, which is going to be our last ditch, almost always, with the exception of vascular anomalies, where that may be the treatment of choice. Another option is vasopressin, which we virtually never use, but I'll mention so that you will at least have heard of it. Most of the time, it's going to be embolotherapy. Vasopressin is a naturally occurring hormone that causes constriction of small bowel wall and splanchnic blood vessels. And you can give it as a drug, and it is useful in some patients, although we very rarely use it anymore unless embolotherapy fails, or if you've got a diffuse inflammatory process. For example, a diffuse gastritis with hypervascularity of the whole left gastric might be more amenable to vasopressin than embolization. So here's an example where it was used actually for a diverticular bleed by one of my colleagues. I'm not sure why I did it, but this is how you do it. This is an IMA angiogram through an IMA. Here's the bleed. And rather than try to embolize it, which is I think would have been the better approach, he decided to give vasopressin, and this is what you want it to look like. This is the ideal appearance. You start the infusion, and then you wait about 15 minutes to do another angiogram, and you can see the bleeding is stopped, but we still have blood flow going to the colon, the marginal arteries filling, and you can kind of barely see vasa recta. So that's a perfect balance between no bleeding and preventing infarction or ischemia. So the problem with vasopressin is that you got to leave the catheter in place for a while, and it's usually temporary, which is why we almost always go to embolotherapy first. It will often fail to arrest bleeding if there's collateral circulation or the catheter moves. Recurrent bleeding is a big problem, and complications related to arrhythmias, fluid retention, and so on are pretty significant. So it's pretty much almost never used. But embolotherapy is the way to go. The rationale is we want to stop bleeding permanently, but preserve bowel integrity. So it's a balance again. We can only do it because there is fairly good collateral circulation, or some collateral circulation in the bowel. But it is riskier in certain patients, and we'll talk about those in a moment. The benefit is it can provide immediate and sometimes permanent treatment. And when it doesn't, at least it will temporize the patient so you can get the patient stable, the bowel cleaned, and do an elective operation, which is much safer than an emergent operation for GI bleeding. The history behind embolotherapy is it was widely used in the 60s, 70s, and early 80s because we could. The problem was it didn't work all the time, and it caused bowel infarction up to a third of cases because our equipment was very rudimentary then. But over the last few decades, we've gotten smaller catheters and wires and materials that we can place exactly where we want, almost anywhere in the body. And now that we can do that, we can do it safely and effectively. And so now embolotherapy is the way to go. The patients in whom I think twice about doing it are these. If they've had surgery in that area or radiation therapy, if I've treated them before with embolization, or if I can't get the catheter well out where I want it, where the bleeding is, and I'm stuck with treating proximally, these are the patients in whom bowel ischemia can be a problem. And you need to think twice about, should I really do this or not? Agent to use, people use all kinds of things, most commonly microcoils and gel foam, although glue, cyanoacrylate, is becoming very popular. And the early studies are showing good results, or perhaps better than with coils and gel foam. There's some question about whether ischemia may be more of a problem, but I think glue may have an important role to play in a lot of these cases. People use particles, and that, as long as they're not too small, that's reasonable. Stay away from small PVA particles and avoid alcohol or liquid sclerosing agents. Where do we embolize? The general consensus is that in the small bowel and colon, you should place embolate material just proximal to the vasa recta feeding the bleed. So in this case, we don't have to go all the way out to the bowel, to the wall of the bowel. We can just put our material right here so that we're going to still preserve some flow through collaterals, but the main conduit of flow is taken out. So right at that level. And this is an example of that. This is probably a diverticular bleed. So IMA, this is the left colic artery, obvious bleed. We bring our catheter out right to here, so we're going to basically occlude right across where this vasa recta is. We don't have to get in there, not necessary, just embolize right there. And that's what we do, and we embolize across it, and we maintain flow in the marginal artery on both sides. Bleeding stops, colon is intact. GI case, huge pseudocyst from pancreatitis with a drainage catheter in place. Patient then starts developing GI bleeding. Now, is it the disease or the catheter? Hard to know, probably not important. But patient develops massive duodenal bleeding. They can't stop endoscopy, so we come in, and you can see the bleed here, obviously, big pseudoaneurysm. And so we're going to embolize basically proximal and distal in the GDA, as we do here. So we get our catheter out, and then we embolize across that area. And then we end with an SMA arteriogram, and the purpose for that is to make sure we're not backfilling the bleed through branches of the SMA. So something we always do when we treat GI bleeding is consider when you're done, or think you're done, that there could be collateral circulation because the arcades are so well developed that could cause persistent bleeding. The case I showed to some of the residents earlier, this is a patient with a duodenal ulcer that they had clipped, and the patient rebled. And so they thought, well, why don't you guys try? Because we weren't totally successful. So we did the celiac angiogram. This is a good example where you do a celiac, we don't see any bleeding, but you do a selective GDA, and we see the bleed. Now, maybe that's just because the bleeding was intermittent. But the general rule is, if you know where the site of bleeding is, do a selective study there. Don't just rely on a negative, non-selective study. So we did that, and then we could have just embolized right across the GDA. My colleague chose to actually get into this small vessel. Whether that's necessary, probably not, or wise, I'm not sure. I don't know. But it may not, the risk in doing that is you may get so selective that you're going to cause ischemia in that area. You really just need to embolize across that GDA to be able to stop the bleeding. Which we did. Again, we checked the SMA to make sure we're not backfilling, and we're not, so no bleeding there. How good are we? Pretty good. Technical success, it's 69 to 100%. I'd probably say nowadays, most hands, 85, 90% of the time we can do it. Initial clinical success, meaning bleeding stops for several days without needing more blood transfusion, all over the map. Probably around 80%, I would say, is probably a good average. 30-day success, however, only about 50%. So the reality is that it's not totally durable. But nonetheless, I think those numbers are good enough to make this the treatment of choice. Recurrent hemorrhage, again, is about 30%. Why do we fail? Well, initially, usually because it can't get in there. when we fail later on, largely because collateral flow was not arrested at the initial treatment, so we didn't do an adequate embolization. Occasionally we'll get recanalization of the embolized site, or there's a new bleeding site, or there's persistent coagulopathy or some systemic problem. But the most common cause is collateral flow that was not treated, so it's doing an incomplete embolization to start with. So that's the first scenario. We see a bleed, we embolize it. Second scenario, we don't see a bleed, but we see a non-bleeding vascular lesion, and this is an example of one. So this is SMA, and here we see this, what we think is actually it looks like it's a bleed, but in fact this is part of a vein. Here's another example. Again, I showed this to the residents earlier. This is the classic appearance of angiodysplasia. So this is an SMA arteriogram. There is this funny tangle of vessels here, but frankly, that alone is questionable. What is not questionable is this early draining vein in the capillary phase of the angiogram. So we're staining bowel everywhere, except here where we're already draining all the way in the portal vein. So early draining vein, we trace back here, and this is an angiodysplasia. So what do? That's angiodysplasia. Unlike an AVM, it is not congenital, but a developmental anomaly. You get this appearance at endoscopy, this little cluster of small venules and capillaries on the bowel wall. Occurs most commonly in the right colon. Unfortunately, when you see one, there are probably multiple. We don't know why it happens, but we do know it's more common in elderly patients. And it can be an incidental finding. This example I just showed you here, this patient had mesenteric ischemia. There's no GI bleeding, so there's no indication probably to remove it. Most of them bleed. When they bleed, they usually stop, but some of them will recur. How do we treat these? A couple options. There is some medical therapy available for some of them that will basically constrict the lesions and will make them less likely to bleed, but that's temporary. Endoscopic treatment of choice if you can get there. Embolotherapy is generally considered not the way to go. And I think that's largely because when we did studies looking at our ability to treat these, we couldn't get out to them. And so we couldn't treat them completely. I think that is changing. This is a case this is actually Tom Kinney, one of my colleagues in San Diego did this. This is an AVM in the cecum, and here's the AVM. There you can see the tram track sign. And this is the standard treatment would be hemicolectomy. But Tom convinced the surgeons to let him try to embolize it. And he did, and he was able to get all the way out to that site, right to the lesion, and put some coils across it, and now it's gone. And at least at 6-month follow-up, it had not, I don't know what the permanent follow-up, but it did not rebleed. So I think we may be moving towards a time when we can treat these and surgeons don't need to, because we can get there where we need to. And so this may change, although the current teaching is still surgery for colonic lesions, you do a hemicolectomy. For small bowel lesions, you do a localized resection. But how do you do that? If I tell a surgeon, you've got an AVM in the proximal jejunum, it's like, where? Well, what do you do? Well, I'll show you what you do. And I know Horacio will appreciate this case. This is a patient of Dr. Musa, who was the chief of surgery at San Diego for a long time. This is a patient with chronic intermittent GI bleeding. Could not find a source. I did this angiogram. I think I was a junior faculty, and I saw something on this. I don't know. I must have been really dedicated, or my eyes were better. But there was a finding that I saw here, which I can't even see on the angiogram now, that caused me to do this selective study. Now, this is actually jejunum. We're in the right upper quadrant, but this is proximal small bowel. It's flipped over, so its geography is wrong, but it's proximal small bowel. I did a selective study, and there it is. That's the tram track I showed before. I said, that's an AVM, I'm sure of it. Well, Dr. Musa, I was junior faculty. He did not believe me. So he went to the OR, and he took out what he thought was a Meckel's diverticulum. She didn't have a Meckel's. And she kept bleeding. So he came back and said, maybe you were right, but how am I going to find it? So what I did is, I did an angiogram, and I left the catheter right here, took the patient to the OR, and then you inject a little methylene blue in the operating room, and I was there, and the bowel just lights up blue. And he just snips that off. And then I took that, I was really young and energetic. I took the specimen, I ran it down to the lab and had my chief tech inject it with contrast, and there it is. Because the pathologist could have trouble finding it. So this is where an IR can be helpful in helping a surgeon take out a very subtle or focal lesion when they could never find it. Finally, what do you do about the negative angiogram, which is unfortunately more than half the time? It will be negative either because of something we did or it's not our fault. And the things we can do is we just missed it. We didn't spend enough time looking at the angiograms. 2, we were not selective when we should have been. Or 3, we did not look, we failed to inject the target artery. So for example, we just didn't look in the right artery at all. More commonly though, it's simply that the bleeding is too slow, or it's venous, or it's stopped, or it's stopping and starting. And this is a good example of the problem of intermittent bleeding. This is a 26-year-old guy that had acquired immunodeficiency syndrome and intestinal CMV infection who had a clear bleed in the cecum. Okay, so this is where CTA is useful. Obvious bleed in the cecum, comes to angiography, obvious bleed. We're going to treat this. We get down here, there it is. And then my colleague starts to move the catheter closer to the lesion, and it stops bleeding. You're stuck, at least in the lower tract, because you can't just take all those vessels out. So this is the problem. Now, what are you going to do? Well, I'll talk about what you can do in this kind of situation in just a moment. You can't do empiric embolization, but you can do that in the upper tract. So for upper GI bleeding, this is now the accepted treatment, which is if you don't see bleeding, but you have any other evidence of where the bleeding site is, you do an empiric embolization. And these are 2 good studies that showed the benefit of that. It was actually done by Sid Padia when he was at Northwestern. He's in our group now. Looked at over 100 patients, acute bleeding, who underwent Embolotherapy, 26 of the GDA, 26 of the GDA, 10 in the left gastric with an identified source, but another 72 patients who had no active bleeding, but there was some suggestion of where the source was. And they embolized all of them, bleeding or not. And what they found is if they did targeted embolotherapy, that is, treat bleeding you see, 44% clinical success. So that's not great, but that's what it is. But if they did empiric embolotherapy, same number. Another study from 2012, a little more over 100 patients with both gastric and duodenal bleeding, looking at what's the primary hemostasis at 30 days. So how many of those patients needed no more treatment for bleeding at 1 month? If you targeted stomach bleeding, 67%. If you did empiric treatment for presumed gastric bleeding, 42%. In the duodenum, the results were comparable. And if you did no therapy, primary hemostasis was significantly less. So these 2 studies collectively suggest that there's some benefit to doing empiric embolization, so that is what most of us do. Example, 78-year-old guy had an AVR and a cabbage, develops melena, bright red blood per rectum, hypotension. Here's an example. Bright red blood is not lower GI bleeding. This was an endoscopically proven large duodenal bulb ulcer, but they could not stop the bleeding. So here, interestingly, we do a celiac angiogram and there's no bleeding. Now how's that possible? Well, we don't even see the GDA. And we don't see the GDA because the celiac artery is partly obstructed. So in fact, what do we do next? We go to the celiac angiogram, of course, and here we can now see moderately enlarged pancreatic duodenal branches, and here's the GDA, but no bleeding from it. Doesn't matter. We know that there was bleeding there before. It may have stopped, but we're going to empirically embolize it, which is what we did. And we went from this end. I don't know that you needed to. It's just kind of fancy, probably not necessary, but just trying to be cool. But we basically got through the GDA from below and then embolized across the whole vessel, and then repeated both the SMA and celiac angiograms, and we've occluded that whole vessel, and of course the patient did not bleed again. What do we do in the lower tract? In the lower tract, we can't do that. So in the lower tract, when we don't see bleeding, but we know the patient is having ongoing hemorrhage or develops rebleeding, provocative angiography. And we're doing more and more of this, frankly, because we're seeing more and more difficult cases. What you do is, assuming you've already done one angiogram that has not shown anything, we give the patient a full dose of heparin. We put TPA, we infuse it into the artery we think is most responsible, and we'll even put nitroglycerin in there too. We have blood ready and surgeon ready. If you do that, in about a third of cases, you'll actually identify a source. Here's an example of that. This is a patient who had upper GI bleeding, angiogram negative. They didn't know at all where the bleeding was. Patient rebled about 12 hours later, and my colleague said, I'm not doing it again unless you give the patient 5,000 units of heparin on the floor right now and bring them down. Now, I don't advocate necessarily doing it in that kind of uncontrolled way, but he did that, and the patient came down, and now we see the bleeding. Now, is it just that it had started again anyway? I don't know. But I think the provocative maneuver certainly can't hurt. So now we see the bleeding, and then we get into the left gastric artery, and there's this branch. There's bleeding coming some in the stomach here, and we embolize that. So provocative angiography is the way to go when the first study is negative. So bottom line, in the last 5 minutes, what do? Patient has endoscopy, and we don't detect an abnormality. Or don't have endoscopy and they want imaging done. Should we do a red cell scan, CT angio, enterography, or catheter angiography? Here's my take. It depends on the patient's situation. And there are 4 scenarios. This is how the patients come to you. Massive ongoing bleeding, meaning they're hemodynamically unstable, they're passing blood maybe every hour, and they have large continuous transfusion requirements, meaning more than 5 units in a 24-hour period. That's 1. 2, and the most common, unfortunately, is slow or intermittent bleeding. Blood pressure is stable, maybe a mild tachycardia, occasionally passing blood, requiring less than 2 units in 24 hours. 3rd scenario, chronic occult bleeding. Patients had an extensive workup for months and months, haven't been able to find the problem, may not even see the bleeding but find chronic anemia. In those cases, it's usually localized to small bowel or ascending colon. Those are really the 3 scenarios. What do? Acute massive bleeding. Resuscitate, correct coagulopathies, and you may need to tell them. You'd be surprised how often the referring docs have just forgotten that. If it is upper GI bleeding, they will usually do endoscopy because they can often find the problem and treat it. We sometimes advocate for colonoscopy, but frankly, we often can't get it quickly enough. If the site is not detected with endoscopy, go immediately to IR. No imaging in between, not with acute massive bleeding. Don't, and this is critical, do not wait for the patient to stabilize. They'll call you and you're waiting to do the angio. We need to get the patient stable. It's like, no, the patient will never be stable until we stop the bleeding, get them down here. That's the whole point. So you need to push the team to be resuscitating on the way to angio so you can stop the bleeding, because that's what they need. And no imaging in between. And this is a good example. Patient has got fairly massive bleeding, hypotensive. You don't do a CTA, you don't do a red cell scan, you want them in IR now. And you get them down, you do a study. Here's non-selective SMA, right ascending colon bleed, probably diverticular. And we do what we need to do. We get out there with our microcatheter, we get out further, we embolize it. In this case, we got out further than I frankly think we needed to, but anyway, they did. I think you could have just come to right about there. But they went all the way into the spacer recta. They stopped the bleeding. Bleeding stops. You repeat the SMA angiogram. Bleeding is done. So bleeding, angio, nothing in between. Second scenario, more common one, active but slow bleeding. Resuscitate, correct coagulopathies. Consider urgent endoscopy or colonoscopy. This is a setting where if you can get them to do that, that's probably a good idea. And they should alert IR. Let them know that there's a case brewing. Now, they don't have to call you at 3 in the morning to wake you up and tell you that, but if the team knows that at least it's a reasonable hour, let them know. And the reason to do that is you then go and you image either with red cell scanning or CT angio, depending on where your institution. I think it ought to be CT angio, but If you're not facile with that, get a red cell scan. And then you have the imagers call you. You don't basically you let your nukes and imaging team know, if you ever get a positive GI bleed, call us, don't call the team. Because you want to go then immediately from the CT scanner to IR. Not CT scanner or nukes, back to the floor, let's get the results, and 3 hours later you find out you had a positive study when the bleeding is stopped. So, and you can make that happen. So you go right from IR, right from the imaging study to IR. Much more likely the study will be positive and you'll be able to stop the bleeding. And this is an example, this is like that case I showed you before of a slower bleeding, probably diverticular bleed at the hepatic flexure. And we basically put out a microcatheter, embolized it, and stopped the bleeding. Scenario 3, chronic obscure bleeding. This is usually due to an angioectasia, that is angiodysplasia, or a true arteriovenous malformation, or an occult neoplasm. Most of the time. Occasionally, it will be one of several other odd entities. What should you do? Well, if they haven't done advanced endoscopy, they need to do it or send the patient somewhere to get that done. Consider if they have not done CT angiography or enterography, particularly enterography, this is the time to do it. If you're going to do catheter angiography, I would push towards a provocative study. You're probably going to see nothing on the conventional study. So I'd advocate set it all up. Say, we're going to do an angiogram. But if we don't find anything, we're going to provoke him. Are you ready? Is there blood in the blood bank? Is there a surgeon at hand? And then you can go, you do the angiogram, it's negative, and you immediately give the heparin, TPA, and so on. And all in one procedure, you can figure out what's going on. This is an example where nukes helped us greatly. 72-year-old woman, obscure lower GI bleeding, has required about 60 units of blood over the past year. She underwent a partial proximal jejunal resection for AVMs, but the bleeding continued. So they did a nuke scan, and this was the scan, and it looks like it's positive here, but we were not certain exactly where that was, and they did a SPECT CT. And they spent some time and specifically said, that bleeding is right where these clips are, the surgical clips are, look there. And I did. And so here is that study. Here's the SMA arteriogram, and I didn't see very much here. Nothing convincingly. So I did a magnified study in a different projection and looked harder. And what I found was what I probably should have seen before. This large vein, early draining vein here, and this artery and a little tram tract sign right where the surgical staples are. And they went in and resected bowel on both sides of it, and she stopped bleeding. So here's a case where the imaging pushed me to look at something and gave me more confidence in making that diagnosis. And that's where I think imaging can be particularly helpful for the IR, is that you have that both pieces of information. You can then say with much more confidence, that's the bleeding, it's worth an operation, it probably will fix it. And then finally, last scenario, negative angiogram. Keep resuscitating the patient. They'll go on to elective endoscopy. If patient rebleeds, consider an angio, CT angio, or enterography, or red cell scan. And if you're going to repeat the catheter angiogram, I would only do it with the plan that you were going to do provocative study. The most annoying thing is to do an angiogram and then 36 hours later they bleed again and it's a different attending and he does another angiogram. And then 4 days later they bleed again and a third attending does another angiogram. You've done 3 angiograms with nothing. That's not good planning. The plan should be, if you are negative on the first angiogram, do a provocative study. Do everything you possibly can to make that work. And with that, I will end. Thank you.
Wonderful,
Questions?
Wonderful presentation.
Questions?
This is really an issue that is very hard to put it in an organized fashion like that. Because many times, the negative studies get you crazy.
Yeah.
That is the problem. When you go, you come in at night, you try to see something and you don't
And
find
you
it.
don't. What do you do? And that's why I think it's
Yeah.
good. It's at that point that you want to make a plan with the team. Okay, what are we going to do when the patient rebleeds? Rather than inventing the wheel again, we all like to make a plan. It's like, okay, if the patient rebleeds, we're going to do a CTA. Or if the patient rebleeds, we're going to do angio, but only if we can do a provocative study. You've got to be okay with that. So have that plan rather than, because they're always sick, and it's like a fire drill every time. And if you plan in advance, you won't have that. And let your other colleagues know so that each attending, because we've got 9 people on call. So it can be, you go from, it's like you're reinventing the wheel. Don't do that. Communicate with the team, this is what we're going to do. Yeah.
So if patient have a chronic renal disease, renal function not good, are you still want to do the CT or angio before
No. Good point. So if you've got someone with chronic renal insufficiency but not on dialysis, where you're trying to limit contrast, then I think doing the CTA early on is probably not a good idea. There you want to, you want to do the money procedure, which is going to be the catheter angiogram. Because you're going to talk about, if you do the CTA and then the catheter angio, you're talking about a lot of contrast. So I would agree, it's a good point. It's a scenario where I think you probably should go right for the invasive procedure and avoid giving extra contrast.
In what scenario would you use the Categorizing blood cell spec CT? Because it seems like that can pinpoint, like, or has the potential to pinpoint, like, very localized. Would you use it as a first line over CT angiogram only in, like, very long-term obscure bleeding? Or
I would use it for obscure bleeding. I think ideally for the patient who just presents with GI bleeding that's sort of moderate, I would go with CTA. And if not, then I'd go with red cell scan. You can ask them to do SPECT, but where I work, getting them to do SPECT is something you're not going to get them to do it at 3 in the morning. It takes some time, takes an attending some time to do it, and to really feel confident about the study. So I think that's the kind of thing I reserve for someone where you've been looking for a while and have failed to find the bleeding. All right, well, thank you.